Good morning or good evening or good afternoon for everyone out there. I am so honored to, with Dr. Gupta and Dr. Cruz for inviting Michelle and I to be part of the panel of reactors. And we've enjoyed participating so far. Today's lectures were absolutely fantastic, and I really appreciated the summary that Dr. Hermosa just like went over everything. There's like almost nothing more to be able to say. I do want to say that what I found listening to all the speakers is that each country has its individual issues that they need to overcome, but several of the themes were the same, right? So we're talking about difficulty with pre-hospital care, difficulty with funding, difficulty with quality assurance, and trauma registries being able to standardize the approach and enforce standardization of approaches. And so I really appreciate that. And I just want to bring kind of a military perspective into this. So when we talk about military and civilian trauma integration, the military is a stakeholder for trauma. So what we exist to do, you know, in the medical side of things is to take care of trauma patients, right? We want to be able to deliver timely, effective care to save our soldiers, sailor, airmen, and Marines, and now Guardians, since we have a Space Force now, from point of injury all the way back to definitive care and rehabilitation. And several of these areas also align kind of with the levels of care or the cluster system that we heard about today. Can we go to the next slide? So we have, in the US, we have a military healthcare system that is a very advanced it's actually international healthcare system with tertiary level hospitals as well as clinics. And that exists in parallel really with the civilian system. And so when we looked at the trauma care that we had done in the conflict in Iraq and Afghanistan, and as those the case volume from that is decreasing, we wanted to see how we could best integrate it, or what would be the benefit of integrating with our civilian trauma system. And the result of that was this report from the National Academies of Science that suggested many areas in which our military and civilian system for the care of trauma patients could integrate so that we could provide more access to care for everyone. Next slide. So another thing that I heard in several of the presentations today is that the military is uniquely situated to take care of multi-organ or severe trauma because of lethality of weapons. When we talk about terrorist attacks or even unusual weapons being used to carry out terrorist attacks, such as biochemical, radiology, sorry, chem bio attacks, sarin, things like that. The military does have those unique capabilities to deploy decontamination units in conjunction with trauma care. These injuries may occur in remote areas, so we have usually the capability of moving patients, stabilizing and moving patients even on the sides of mountains, in the middle of the ocean, no matter where they may happen to be. And also we are used to caring for patients when it is potentially unsafe for rescuers or healthcare providers, as was mentioned in several of the talks today. And we do have mobile and expeditionary infrastructure when we're talking about responding to disasters. This picture here is actually a EMEDS, or an expeditionary medical facility, which is a self-contained hospital that has a two-room operating room. So that's actually the OR table, and you can see the lights and the anesthesia machine that comes out of a box. We have the capability of sterilizing equipment as well as generating power and generating oxygen within this one containerized hospital that can fit, the entire hospital can fit in the back of a C-130. Next slide. And so the question is, well, if the military has its own trauma system and the civilian side has its own trauma system, why would we integrate? What is the benefit of it? And so one of the things that we're looking at is what is the potential avenues for integrations. One of the some of the findings from the Zero Preventable Deaths that came out is that we can leverage the military experience to improve general trauma care. Several things that have come out recently from our experience in Iraq and Afghanistan, and being able to have a massive registry of all those injuries, have given clinical practice guidelines for transfusion of blood, for hemorrhage cessation, for using TXA. All of those things have kind of come out of the body of knowledge of war. And then additionally, we talk about you know, we need to be able to do trauma care, but when we are not in conflict or if we're not responding to a disaster, we are not receiving casualties. And so there is a need for military surgeons to integrate with the civilian side to be able to keep these skills fresh, because if you're, as Dr. Lau mentioned today, there is a minimum amount of trauma that you need to see to be able to adequately do it when you're called upon in the future. And then this is also an opportunity, not just nationally, but internationally, so that other nations' militaries can engage with your country's militaries for the avenue of trauma system development, because it is important for us worldwide. Next slide. And so as we summarized today, everyone said it needs to come from top down policy change. We need to identify stakeholders and find equitable partnerships. And then we propose considering civilian and military integration for improving national trauma care. I think that's the last slide. And our contact information's on there.